Okay, I think we'll go ahead and get started. This is Lauren Baldessari. It's 8 o'clock. Looks like we have a fair number of participants signed in. So good morning, everyone. I'd like to introduce our own Dr. Krishna Upadhyaya today. He's going to be giving us a great grand rounds on cardio-oncology, cancer-therapeutics-related cardiac dysfunction. Krishna did his medical school at University of Rochester. Then we were lucky to have him here for internal medicine in Yale, at Yale. And then we were even more lucky to have him stay on to continue his cardiology fellowship with us here at Yale, where he currently is a third-year cardiology fellow. And he has been working with us in cardio-oncology. He participates in our cardio-oncology continuity clinic and really has done a great job helping us to take care of these often very complex patients. He also took on quite a task this year with myself and Dr. Sarah Hall and other collaborators in writing a review, a chapter on cardio-oncology for a oncology book, which he did a really excellent job in. And he will be joining, after he graduates, he will be joining some of our prior fellows and faculty in Milwaukee, Wisconsin, where he will be practicing general cardiology as well as growing cardio-oncology practice there as well. So let Krishna go ahead and get started now. And if people have questions, I think what we're doing is you could do a chat, write in a chat question, and I'll take a look at those as we go throughout the presentation and save those for questions at the end. Otherwise, at the end of the presentation, you can raise your hand.
Good morning, everybody. Thank you so much, Dr. Baldessari, for that wonderful introduction. I hope everybody can hear me okay, and thank you for joining for our first virtual grand rounds. So I'm Krishna. I'm one of the current third-year cardiology fellows. So I'm going to be talking about cardio-oncology, cancer-therapeutics-related cardiac dysfunction. So I'm going to start off with a case. This was actually a patient that we saw fairly recently. This is a 31-year-old female with a history of breast cancer who presented for newly reduced EF. She was diagnosed just back in July of the past year, and it was a HER2 positive, and there was a little bit of cancer in the node, in just one of the nodes, but there wasn't any systemic metastasis. And when we had seen her, the only symptom that she really reported was this chest tightness that was fairly infrequent. It only started after her treatment had started. It was fairly atypical. She otherwise had no shortness of breath or any other kind of heart failure symptoms. A little bit about her past history. As part of her staging workup, she had this subsegmental PE that was incidentally found. She was treated with Xarelto for 6 months, and then her repeat scanning actually showed no residual thrombus, so that was stopped. Because she was very young, she was tested for BRCA, and that was negative. Nothing particularly significant in her past surgical history. She had tonsillectomy, and she had notably no family history of early heart disease in her family. Social history-wise, she has some occasional cigarette use as a teenager, never had a habit of smoking, and had no alcohol or drug use. And she was not on any cardiac medications at the time. Her physical exam really was fairly unremarkable. Notably, there was really no signs of heart failure on her physical exam. And in terms of her laboratory data, again, everything was fairly unremarkable. She did not have any troponins or BNP checked at that time. So her oncology treatment plan that she had gotten before she had seen us, so she had gotten 4 doses of doxorubicin and cyclophosphamide, and the dose that she had gotten was 60 milligrams per meter squared. And so the total dosage that she received was 240. And part of the talk, we're going to talk about why that's important. And then after that, she had 12 additional doses of Taxol, Herceptin, or Trastuzumab, and Trastuzumab, which is also a tyrosine kinase inhibitor. And then when she had come to see us, her plan also, at her own request, was to eventually get bilateral mastectomies. So the images here show her initial echocardiogram back in August. This was pre-treatment on the left, and then on the right, this is her kind of follow-up echo after treatment in January. Unfortunately, the 4-chamber images were not very good quality, so I'm starting off with the 2-chamber here. So here we can see anterior wall, inferior wall, and we can see that overall the function seems pretty preserved. All the wall motion, all the walls are coming in nicely. But when we look at the echo in January, it looks like the walls are not coming in as well. The function seems a bit reduced, but it looks fairly global. There's no kind of regionality to any hypokinesis. This is her 3-chamber view. So we have our anteroseptal inferolateral wall here. And again, it's a little less clear in the 3-chamber, but I think we can see again, there's this kind of global hypokinesis as compared to the August echo. And then I think where it's most evident, where we see it best, is in the short axis here. So you can again see that it's kind of nicely all coming in normally back in August, but then in January, we can clearly see that there is some global hypokinesis and the walls overall are not coming in as well. So by 3D echo, the EF in August, her pre-treatment EF was 61%, and her EF by 3D in January was read as 49%, so reduced EF. She also had a global longitudinal strain that was done as part of her January echo, and that was also abnormal, just about minus 14%. We're going to talk more about this later in the talk. So she did actually undergo a cardiac MRI. So this here is a short axis stack of images. So we have the left ventricle here and the right ventricle here. And as we can see when we play this, overall, the function again looks reduced. It looks global. All the walls are just not coming in well. And you can sort of see in some of the images, it's a little laggy, but there's some tracings here. And so the way that we calculate our EF here is we measure circle the endocardium and circle the epicardium, and using kind of basically we look at from the base to the apex in the short axis, and we can calculate volumes and then help use that to determine EF. And so the EF by quantitation on CMR came out to be even a little lower at 41%. In CMR, we also look at LGE, or late gadolinium enhancement, which looks at evidence of scar or fibrosis, and that shows up as this kind of lighting up here. And so what we see in this image is there's a little bit of lighting up kind of here at the RV insertion site, which is a fairly non-specific finding, but we're going to talk a little bit more about LGE and CMR and anthracycline toxicity later. So we're going to come back to our case at the end. So the learning objectives that I wanted to go over today. So I'm going to review some of the background, history, and definitions of cancer therapeutics related cardiac dysfunction. And then I'm really going to focus most of my talk on specifically anthracycline related cardiotoxicity. We'll go over the diagnosis and management of that. And then finally, I'm going to outline some selected other chemotherapy drugs, namely the ones that our patient was exposed to, and just briefly go over some of their effects. So starting off with some background information. So there's a significant population of cancer survivors nowadays because of effective detection and good treatment strategies. This is data from SEER, which is the Surveillance Epidemiological and Results database, which is part of the NIH. And what they showed is that, and this is fairly recent data, that 2/3 of patients that have cancer are actually surviving out to 5 years. When we look at kind of absolute numbers from the National Cancer Institute, in 2016, there were more than 15 million cancer survivors in the United States, and that is expected to grow to 20 million by 2026. So in addition to patients having adverse effects to their heart from their chemo, these patients are actually now living long enough where they're at an age that cardiovascular diseases actually start manifesting. And this is from a retrospective cohort study of about 63,000 patients back in 2011. And you can see that over time, actually, these patients are actually dying from cardiovascular disease even more so than from their own breast cancer. So a little bit about the history of chemo-related cardiotoxicity. This was kind of originally described in the 1960s and 1970s, namely with adriamycin, and it was seen as this toxicity where patients were manifesting symptoms of heart failure. This was kind of a landmark study by von Hoff and colleagues in the late 1970s, and this was the study that kind of established this kind of dose-dependent or dose-related increase in risk of CHF with increasing dose of anthracycline. And specifically, they had commented in the paper that at these different doses, 400, 550, 700, there was an exponentially increasing risk of cardiotoxicity. And we're going to come back and look closer at this paper a little bit later. So I want to go now over some definitions in this realm. So CTRCD, cancer-therapeutics-related cardiac dysfunction, has since been kind of recognized as a major side effect of not just anthracyclines, but other chemotherapeutic agents as well. And there's a little bit of differences based on the society that you look at in terms of the definition. When we look at the ASC, or the European Association of Cardiovascular Imaging definition, we see they define it as a decrease in LVEF of by greater than or equal to 10% to below 53%. And this should then be confirmed with repeat imaging in a few weeks. Whereas ESMO, which is the European Society of Medical Oncology, takes this one step a little different. They kind of divide it based on symptoms, and so their cutoff is 55%, so a drop in more than 5% to less than 55 if the patient has symptoms, or a drop in more than 10% to less than 55 if they are asymptomatic. Generally, we kind of use the ASC definition in our practice. So there's kind of two broad ways of thinking about CTRCD and classifying it. There's type 1 CTRCD, which is what we typically think about with doxorubicin or anthracyclines. And kind of the features of this is that it tends to be a more permanent or irreversible damage to the heart. It tends to be more cumulative and dose-related, and you see these ultrastructural changes, like on electron microscopy, of damage to the myocardium, and that may explain some of the why it's permanent and irreversible. And that's in contrast to kind of type 2 CTRCD, which is has a higher likelihood of recovery, even if you have cardiotoxicity. It tends to not be dose-related, and you don't really see any apparent ultrastructural abnormalities as compared to type 1. And this is what we typically see in Trastuzumab. So this is kind of a general way of thinking about CTRCD and classifying it. But when we look at some of the newer agents like tyrosine kinase inhibitors and immune checkpoint inhibitors, they don't quite classically fall into this type 1, type 2. I think it's a nice way of thinking about some of these medications. So a little bit about, I'm going to kind of chalk up now more into anthracyclines, a little bit of history about anthracyclines. So the original anthracycline was actually isolated in the 1950s. It was called daunorubicin, and this was isolated from a gram-positive bacteria called Streptococcus pudicus. And there's actually, or Pusidus, and there is actually a very interesting this kind of historical tidbit here. So this was initially actually discovered by two different groups. One was in Italy and one was in France, and it was kind of discovered in the same year, so around the same time. And the group in Italy actually named it initially Daunomycin because the area that the bacteria was discovered used to be an area of this, was called the Dauni tribe, which is a pre-Roman tribe in that area. Whereas the French had called it Rubidomycin, ruby being red because the bacteria produces this red pigment. And so kind of when daunorubicin initially came to market, the names of the two different groups were actually combined together into daunorubicin. And then later on, doxorubicin, also known as adriamycin, was developed as kind of more effective derivative of daunorubicin. And then just so that you've heard of the other ones, the other anthracyclines typically include epirubicin and idarubicin. So the mechanism of action of doxorubicin is it's not really well known, it's not fully well known, but there's kind of two main mechanisms that are thought to cause its anti-tumor effect. So once it comes into the tumor cell, one thought is that some research has shown that doxorubicin goes into the nucleus and actually interferes with topoisomerase 2, which is typically used in the enzyme that's used in DNA unwinding and DNA unzipping in replication and repair. And so it goes and impairs that, and that then leads to DNA damage, which then leads to cell death. The other thing is that doxorubicin undergoes a lot of these oxidation reduction reactions between this it turns into like a semiquinone and then kind of goes back and forth, and that creates a lot of reactive oxygen species that also causes oxidative stress that also leads to cell death. I'm going to come back a little bit more into this when we talk specifically about mechanism of cardiotoxicity. So the presentation in terms of when patients come to you, so I said anthracyclines typically they classically fall into this type 1 CTRCD. They can actually cause this acute or chronic cardiotoxicity. The acute tends to be either during infusion or within a few days of administration, and manifests more as a myopericarditis or an arrhythmia or chest pain. These patients actually rarely see a drop in LVF, and this is actually generally reversible with prompt supportive treatment. So when we're talking about this kind of classical type 1 CTRCD, we're actually not specifically talking about the acute. We're talking more about kind of the quote, chronic cardiotoxicity. So this is more of what we see, I think, in our clinic. So these are patients that develop toxicity over within a month of administration or actually many years later. And this is the one that we see, cardiomyopathy with reduced LVEF, that is often irreversible because of cellular damage. So for the rest of my talk, I'm going to be really just talking about the chronic cardiotoxicity. So the way that patients present, you may initially see patients complaining really of signs of limited cardiac reserve. So they may have this tachycardia at baseline or a slow return of the heart rate to their baseline. They may notice that previously activities that didn't cause them dyspnea now do cause them dyspnea. They may have fatigue out of proportion to their activity level, again, suggesting limited cardiac reserve. And then you may see progression to more actual overt signs of heart failure like orthopnea, weight gain, fluid retention. So I'm going to talk a little bit about kind of the history of the cardiotoxicity of anthracyclines. So before the early 1970s, there are a lot of case reports of people noticing toxicity with these agents. And Lefranc and colleagues in 1973 were kind of one of the first groups that did kind of this bigger study. So they looked at 399 patients that underwent adriamycin treatment. And they basically looked at patients that developed symptoms of congestive heart failure. So in this study, they hadn't looked at LVEF, which we traditionally look at now. They were just looking at symptoms of congestive heart failure. And what they saw is that there was kind of this pretty sharp cutoff right around a dose of 550 milligrams per meter squared. And so what they said was that below 550, there was only one case of congestive heart failure, but above a dose of 550, it jumped up to 10. And so their conclusion was that the total dose of adriamycin should be limited to less than 550 to permit its safe use, because it is efficacious for cancer. In this paper, they also did look at autopsy results and did electron microscopy. And so what they saw is that there was just significant kind of disarray of the myofibrils. There was a lot of cell death, fibrosis. They looked at it closer, and looking specifically at the mitochondria, they could see that the mitochondria were swollen. There was all this kind of dense inclusion body material and just overall disarray. This is just from a more recent kind of paper, and it's colored. So this is kind of normal myocardium on the left, and then this is patients that have been affected by anthracycline toxicity. And again, you can just see swelling, you can see disorganization of the matrix, fibrosis, etc. So those are some of the ultrastructural changes that you see. So the mechanism of anthracycline cardiotoxicity is similar to how it actually works in treating cancer. And so as I showed before, there's this reactive oxygen species generation that can have several different effects. It can actually have signal transduction effects that lead to apoptosis. One of the specific things I wanted to point out is that doxorubicin can actually form complexes with iron, and in this process can also generate reactive oxygen species. And we're going to actually talk a little bit more about why this is important to point out a little bit later in the talk. The other thing is the reactive oxygen species and doxorubicin can actually affect cardiolipin, which is in the membrane of the mitochondria specifically. That can cause cytochrome C release, which then leads to apoptosis. And as we know, a high fraction of the cardiomyocyte volume is made up of mitochondria, and so that's why it's thought it affects the heart so much. And then we fast forward a couple of years to 1917, where Von Hoff and colleagues kind of took this study one step further. This was a much larger retrospective analysis of 4,000 patients that had doxorubicin treatment. And basically, again, they also looked at clinical signs and symptoms of congestive heart failure secondary to doxorubicin and kind of diagnosed patients that way. They did not use any LVEF at that time. And they saw that there was an overall incidence of 2.2% of doxorubicin-related cardiomyopathy. And this is kind of one of the very beautiful graphs that he generated in his paper, showing that it wasn't just a cutoff of 550, as we saw in LaFranc's paper. There's actually very much a dose response curve. And so at differing levels of dose, there's actually exponentially increasing risk of probability of CHF. So this was a kind of very elegant paper showing this nice dose response to increasing risk of CHF with total dose. He then took that one step further and also stratified patients based on different variables. So in this graph on the right, he actually looked at patients that had 3 different dose schedules of administration. So patients that had infusion every 3 weeks, 3 days every day, every day for 3 days, every 3 weeks, and then a weekly administration. And he saw that actually made a difference in the probability of developing CHF. And so the patients that had it weekly, especially in the higher doses, at any given dose, had lower risk of developing CHF than patients in some of the other schedules. And the thought with that is that with the weekly administration, you were giving a little bit less kind of upfront dose over a longer period of time than kind of a higher upfront dose. They also looked at risk stratification by age and saw that older age was actually a higher risk of developing CHF as compared to patients that were younger. So that is a significant risk factor. And then they also looked at whether the patients having prior cardiovascular disease, such as hypertension, MI, also made a difference, which it did. And so patients that had prior cardiovascular disease also, for any given dose, had much higher risk of CHF. So this was a very kind of elegant study that showed, again, the dose response curve and several different risk factors that also affect probability of CHF development. And then looking at a little bit more recent data, Swain and colleagues in 2003 did a nice retrospective analysis of 3 phase 3 studies for a total of 630 patients. 2 of them were breast cancer studies and 1 was a lung cancer study. And here they finally started incorporating looking at EF in addition to CHF symptoms. In this study, they looked at EF using MUGA scanning. And what they found was that there was an overall increased incidence of doxorubicin-related cardiomyopathy. And the reason for that is probably because they were also looking at EF, which Von Hoff and LaFranc were not looking at the time. So what they saw is that as compared to Von Hoff's paper with the dose response curve, at any given dose, there was at higher doses, there was a higher risk than what was reported in Von Hoff's paper. So in Von Hoff's paper at 550, the probability of developing CHF was more around 7%, but Swain and colleagues showed that it was actually higher at 26%, probably because they're including EF in addition to CHF. And they also showed that patients that what was thought to be previously, it was thought that lower doses were not as high risk, but they did show higher step off at lower doses. And so based on this data, people actually started thinking of a cutoff of more of 450 rather than 550 in terms of max dose. Now, what about patients in terms of long-term risk? So patients that have had cancer when they were younger, have been exposed to these agents, what happens to them in the long term? So there's a nice study by Mulroney in 2009 that looked at the childhood cancer survivor study cohort of patients. This was a retrospective cohort study from 26 institutions with a large number of patients, over 14,000 patients. And they looked at patients that were at least 5-year survivors of these various different cancers that were under the age of 21 in this time period, and then kind of followed them now into adulthood and later. And what was interesting about this study is they also looked at the siblings of a lot of these patients as controls. And they looked at the primary outcome measuring the incidence of and risk factors of CHF and other cardiovascular abnormalities. And I will point out in this study, this wasn't specifically looking at anthracycline. This was just kind of cancer and chemotherapy in general, but about half the patients in the study, in the cohort, were exposed to anthracyclines. So what they saw was actually very interesting. There was, when they compared patients, the survivors, to their siblings, there was a much higher risk of not just congestive heart failure, as we can see here, but all other cardiovascular conditions as well, myocardial infarction, pericardial disease, valvular abnormalities. So these patients, even when they're exposed at younger ages and they survive their cancer, there's definitely effects that we need to be thinking about the older they get and the longer out they are from their treatment. In that paper, they also did look specifically at the anthracycline group and risk stratified them based on a dose of 250 or more or less. And they also saw that the patients that had more than 250 milligrams per meter squared of anthracycline did have greater cumulative incidence of these factors as compared to patients that had less than 250 or no anthracycline dose. So there's definitely a long-term impact in these patients when they're treated at younger ages as well. And so just kind of summarizing the risk factors that we've talked about based on this data, cumulative anthracycline dosage is a very important risk factor, as we saw so nicely laid out in the Von Hoff paper. Higher individual dose, and this kind of also increases risk, and this sort of plays into different schedule of administration, so higher individual dose versus lower individual doses over time. Age clearly has a role in this as well. And comorbid cardiac conditions, patients that have comorbid cardiac conditions also have higher risk at any given dose of increased cardiotoxicity risk. And then also exposure to anthracyclines and other agents, when they're kind of combined together, those patients have higher risk than just a single agent. As well as radiation exposure also has higher risk. And there's also some studies that looked at gender and actually showed that female gender had higher risk. So I'm going to talk now a little bit about diagnosis. So our mainstay of diagnosis, our two modalities, are echocardiography and CMR, cardiac MRI. So I'm going to talk more about those two individually, but I just wanted to highlight one kind of key point here is that a lot of our patients, that even though they have exposure to anthracyclines and they have risk of cardiotoxicity, common things are still common. And so patients still can have ischemia and other causes of heart failure. And so it's important, that we test them guided by their symptoms. So we want and their risk factors. So a lot of our patients, we do coronary CTAs to evaluate our coronary arteries. And so the point here is that even though these patients have exposures, they can develop cardiotoxicity from other causes, and we don't want to miss those causes, A. And B, we don't want to hold someone's chemotherapy when the cardiotoxicity is caused by something else and not anthracycline. So they're missing out on kind of cancer treatment there. So we do a lot of concurrent testing as well. So echocardiography, and so the main kind of thing that we're evaluating here is LVEF. The beauty of echocardiography is it's the preferred initial imaging modality because it has very widespread availability. It comes at a low cost, and there's a great safety profile with it. There's a nice study by Armstrong in 2012 looking at kind of what is the best way to evaluate EF in these patients. So he had looked at, the group had looked at 114 adult survivors of childhood cancer exposed to anthracycline chemo. And they looked at 2D echo, 3D echo, and CMR, and kind of used CMR as the gold standard here. So these are the test characteristics that they saw echocardiogram as compared to CMR, and they had used a cutoff of an EF of 50% as their definition here. So our test characteristics actually with 2D echo, the sensitivity was only 25%, but with 3D echo, it did increase a little bit there. Part of the issue is that the number of patients are actually kind of low, and so that can definitely skew some of the results. But when they looked at comparing 3D echo and MRI EF, they saw that there is this kind of small portion of patients that echo is diagnosing as a normal EF, but by CMR, they're actually low EF. And so for 3D echo, it was about 6%, and whereas for 2D, it was about 11%. And overall, the mean 2D EF was about 5% higher than EF derived from CMR. And so typically, when we're sending patients for echocardiogram, we prefer if you can get 3D echo, since that has better correlation, and that's what's recommended by the guidelines as well. The nice thing about echo is that there's a lot of other things, other information that you can get in addition to just LVEF. So you can look at RV function. Unfortunately, the prognostic value of RV dysfunction has not really been studied well, so we don't know what that means. But there are certain chemotherapeutics that can cause things like pulmonary arterial hypertension. So it'd be important to get an RVSP and keep an eye on RV function in these patients as well. Valvular disease is also important to look at. So patients are immunocompromised when they're getting treated. They can develop endocarditis. They can have morantic endocarditis. Patients, once they develop heart failure, can have secondary regurgitation. Radiation exposure can also lead to calcification and stenosis of valves. So you get a lot of information on the valvular disease when you look at the echo as well. And then finally, you can also see issues with pericardial disease. So things like pericardial effusions or pleural effusions. You can also see constriction. So you get a lot of information from the echo, more than just the LVEF. So when we look at cardiac MRI, this tends to be kind of the gold standard for not just LV and RVEF, but for LV volumes and RV volumes. And the nice thing about this is that the modality gives you good distinction between endocardial and epicardial borders. And so we get to kind of bypass some of the geometric assumptions as well compared to echo. But the downside of it is that it is much more expensive and it is much less available. And so we have to factor those in. So there's kind of three factors that are different than LVEF that we can see in CMR that have been have some prognostic value. So myocardial mass is one of those. So this is just, again, a short axis slice. And the way that we do this is in green here, we have contoured the epicardium, in red, the endocardium, and the yellow here is the RV. And so we can look at this in a short axis stack from the base to the apex and actually calculate the myocardial mass from that in addition to the LVEF. I'm also going to talk a little bit about LGE, or late gadolinium enhancement, and what role that plays. And the way that works is gadolinium normally doesn't really enter into intact cell membranes, but if you have some kind of rupture in cell membranes, it can enter there for a period of time that you can see, like an infarction, or in patients that have scar or fibrosis, the gadolinium kind of gets caught up here in the matrix, and so we can see that as a finding as well, and we're going to talk more about that. And then lastly, this is one of the more kind of emerging concept, is looking at extracellular volume. So in terms of myocardial mass, there's kind of a nice study by Nealon's group in 2013. They looked at 91 patients with anthracycline-related toxicity that underwent CMR. And what they were basically looking at several different variables on CMR, and then looking at an endpoint of cardiovascular death, needing to put an ICD, admission for decompensated heart failure, so that they could see if any of those variables from CMR were prognostic for this endpoint. So they followed patients for about 27 months, and they noted 52 events in this study period. And so what they noticed actually was there was a correlation between left ventricular mass index, or myocardial mass, and anthracycline dose. And what they saw is that in higher escalating doses of anthracycline use, there was actually a decrease in left ventricular mass index. So the higher the dose, there was a decreasing mass index. And what they saw, interestingly, was that when they stratified based on a mass index of 57, the patients that had lower mass index had less event-free probability, whereas the patients that had more than 57 actually, very interestingly, had no events. They didn't specifically comment on that, but I thought that was interesting. So the LV mass index may be a prognostic variable that we can use in these patients. In terms of LGE, so I had mentioned that LGE can help us look at scarring, fibrosis. The thing that also depends is the pattern of LGE and how it looks. So we can see different patterns. So in patients that, for example, have ischemia or ischemic injury, you can see transmural LGE, you can see subendocardial LGE. With non-ischemics, you can see more of this kind of non-specific mid-wall findings. In anthracycline, interestingly, a lot of times there ends up being no LGE. So in that same paper by Neelan's group, they commented that LGE was actually a very infrequent finding. Only about 6% of patients that had anthracycline cardiotoxicity had any notable LGE findings, but they were kind of in this non-ischemic pattern. And particularly as related to our patient, RV insertion point is something that's seen. There isn't a lot of data out on this currently as to what this means, but I know Dr. Baldassari is currently looking at this because we've noticed a lot of our patients that get exposure to these drugs do have this RV insertion point LGE, but it's not sure what that means exactly. There's some thoughts in some of the papers as to why this might be, why we don't see LGE. One thought is that, so as I said, it kind of goes in and is trapped by these areas of scar in the matrix. And as we saw in some of the ultrastructural studies earlier, there's thought to be this may be diffuse scarring and diffuse fibrosis. And so the way that we look at LGE, it's similar. If you think about in nuclear studies, we're looking at kind of relative areas of contrast and so the LGE might be that we may not see it because we see that there's fibrosis everywhere, and so we don't see kind of relative contrast differences. And so one of the kind of more recent emerging factors that has been looked at is looking at extracellular volume, which is a ratio of the myocardial interstitial space, so the total volume of myocardium, including the myocytes and such. And what we know is that increased ECV is most often due to excessive collagen deposition. And so that's something that is kind of a more robust measure of myocardial fibrosis and perhaps something that we can measure. And so this was actually interestingly studied by the same group in the same year. They released a paper. They looked at 42 patients with anthracycline-based chemo, and they compared them to normal patients. And so this is looking at the ECV volume fraction here in controls, normal healthy volunteers. And then these are all patients that have been exposed to anthracycline. So this is patients that still had a preserved EF, and then patients that had a reduced EF. And so what was interesting is that anyone that was exposed to anthracycline, they saw that there was an overall higher amount of ECV than the control. And interestingly, when they look specifically at reduced ejection fraction and preserved ejection fraction, the reduced ejection fraction patients had a little bit higher ECV fraction than the preserved. And so in the paper, they mentioned that perhaps this may be a little bit of a continuum in the sense that perhaps these patients are getting fibrosis and some damage initially early on without dropping in their EF, but then as they're exposed to more and have more cardiotoxicity, then they start reducing their EF. There's also an interesting kind of letter to the editor with this paper where they looked at, they commented on the fact that ECV is actually a ratio. And so they commented in the paper that the ratio can be increased for two reasons. One, you can have an increase in the numerator. So you can have increased volume of tissue within the interstitial space from excessive fibrosis, or you can actually have a decrease in the denominator, which can be seen as a loss of volume in the myocardium from loss of myocytes and necrosis and things like that. And so in that paper, they commented that in the future, it would be helpful to consider which of these might be contributing more, as that may have some kind of therapeutic implications down the road. Again, similar to echo with MRI, we also get a lot of additional information beyond the factors that I already mentioned. So RV function we can look at, but again, there isn't great prognostic data on that. One of the nice things about CMR is that we can get a better look at masses in tumors. So we can differentiate things like thrombus, we can look at invading cancer, we can look at valve vegetation and see is it thrombus or something else. So get a little bit kind of extra information from that. Again, we can also look at pericardial disease, looking at effusion, constriction, things like that. So we get a lot of information when we do these studies. So what I've talked about so far, though, is patients that have already developed LV dysfunction. And so the concern is that once they've already developed this dysfunction, there may be it may be irreversible. And so how can we figure out what are markers that we can use where we can look for subclinical markers of dysfunction? So things that'll kind of clue us in as to when a patient may develop issues down the road. And so there's kind of 4 things that I'm going to touch on. So we're going to talk about endomyocardial biopsy, global longitudinal strain, troponins, and BNP. So endomyocardial biopsy, this was actually, some of the data actually goes back to the late 1970s. There's a nice paper by Bristow that looked at endomyocardial biopsy on 33 patients that had doxorubicin exposure. And what they did was they assigned a pathology score. And so 0 was totally normal. 1 was if you had some scan T cells showing some early changes. 2 was more widespread changes. And 3 was kind of diffuse myocyte damage, marked cellular changes, frank necrosis. And what was interesting about this study, so we see pathology score plotted to doxorubicin dose. And I think what's interesting here is that we see that patients even less than 300, almost in even the 250 and less range, they're actually starting to show these ultrastructural changes. And so we may not necessarily see that manifest as an EF drop or symptoms at that point, but we're already seeing that there may be damage to the myocardium. So I thought that was an interesting thing from the paper. The issue is that endomyocardial biopsy is invasive. There is risk of perforation and tamponade. So this is not something that currently we use routinely, but it is something that we can use. Global longitudinal strain is a nice kind of non-invasive measure that we can use. So what GLS is, it measures deformation, which is a change in the length along a cardiac coordinate axis of a myocardial segment during systole as a percentage of its original length and diastole. So the way you can think about it is kind of as like a spring, and you're kind of crunching the spring and letting it relax and contracting and relaxing. And so we're measuring that deformation. So when we look at this in echo, we look at it in kind of 3 different coordinate axes. So we have global longitudinal strain, which looks at contraction in this plane. We have radial strain, which looks at thickening and contraction in kind of this plane. And then we have circumferential, looking at in the short axis in this plane. So we have kind of 3 different coordinate axes that we can look at. And then the way that this data is kind of presented when we read our echoes is in this bullseye plot. And so we have this kind of 17 segment model here that then generates, in this case, a global longitudinal strain. And it's negative because we're looking at contraction and thickening here. And so we're going to talk a little bit more about this. So what is normal strain? There's actually a lot of debate in the literature about what exactly is our normal strain. There's a nice meta-analysis from Ying Chancharan in 2013 that looked at 24 different studies with almost 2,600 patients. And what they saw in the meta-analysis was they concluded that the overall normal mean GLS was minus 19.7, so just around 20. And this is the number that's been used in the 2014 ASC guidelines as well. So the issue with this, though, is that why they were seeing so much variability in a lot of these studies is it depended very much on the vendor. It depended on the analysis software version. It depended on age of the patient, gender, load dependency. So there's a lot of factors that can affect kind of finding a normal mean GLS. And so does what kind of prognostic ability does GLS have? So this was presented in a nice meta-analysis in 2014, looking at 8 different studies, looking at the prognostic value of GLS during active treatment. And this is a representative patient case from that paper. So they talk about this patient that had a pre-therapy EF of 61%, had a normal GLS at that time. And then 6 months later, they noticed a little bit of a drop in EF. Doesn't quite meet criteria for CT-RCD by ASC guidelines, but they did notice that there was a drop in GLS, about a relative drop of about 15% here. And then when they looked at EF 6 months later, then now the EF had actually dropped to 49%, and that is actually met criteria for CT-RCD. So when they looked at the data from all these meta-analyses, they saw that a fall of about 10 to 15% in relative GLS was predictive of subsequent cardiotoxicity. And these are the test characteristic ranges that they saw from the various, looking at all the various studies. Unfortunately, with global radial strain and global circumferential strain, those were not particularly predictive. There's some of the thought as to why that might be is if we look back at our kind of coordinate axis here, the longitudinal strain kind of aligns nicely in the axial direction with our ultrasound beam. And so the thought is that perhaps you get better spatial resolution there and you can kind of characterize it better. But the studies didn't really bear out in these 2 factors. So when we look at the ASC guidelines, this is kind of the recommended algorithm. So if you don't have CT-RCD, but you look at a drop in GLS, they consider more than 15% as a marker of subclinical LV dysfunction. But if it's less than 8%, there's no great evidence of subclinical LV dysfunction. But as I kind of mentioned, the things that we think about here, there is a lot of variabilities in the studies that looked at this in terms of just definition of CT-RCD. What does strain in long-term in survivors mean? So if you have a patient that had exposure and now has a drop in their GLS, what does that mean? Do you stop chemotherapy in patients that have a drop in GLS? These are all kind of some unknown factors that still need to be studied. Troponin was studied by a group in 2004, Cardinal et al. So they looked at using troponin I as a risk stratification for patients undergoing high-dose chemotherapy. This was a prospective study in Italy of 703 patients undergoing high-dose chemotherapy. And what they did is they measured troponin kind of before and soon after each cycle. That was designated as, quote, early troponin. And then they measured it 1 month after the last administration, and that was designated as late troponin. And then they looked at the primary endpoint was occurrence during the follow-up of all these various cardiovascular events. So what they saw is that when they looked at these patients, they saw kind of 3 different groups of patients. They saw patients that either had normal troponin or negative troponin initially, and that remained negative throughout their treatment. They saw a group of patients that had a slightly positive troponin initially, but then that decreased by late troponin. And then they saw a group of patients that had a positive troponin initially that only increased as time went on, as treatment went on. And so when they looked specifically at those 3 groups and looked at patients that had some of these events like a drop in EF, they saw that the patients that had initial positive troponin that remained positive made up more of these patients than patients that didn't have troponin either initially or during the study. And at every level of drop in EF, these patients with the positive troponins made up a much higher part of that group. And when they looked at kind of longer outcomes, or when they looked at the outcomes, they saw that patients, again, that had positive troponin had this lower event-free survival event rate as compared to patients that had negative troponin. So this is something that we use as a marker when we're following our patients and is recommended by the guidelines. Now, BNP, unfortunately, the data is a little bit mixed. This is one paper from 2012 that was a prospective study looking at biomarkers and chemo-related cardiotoxicity with 81 patients with new breast cancer that measured some biomarkers and then LVEF. Unfortunately, when they looked specifically at BNP kind of before treatment and throughout to the end of treatment, there really wasn't any change. They didn't think that it was a great marker. Whereas the year before, another paper looked at, by Romano's group, looked at, it was a prospective study looking at BNP and development of anthracyclines. So this was in 92 patients where, again, they measured BNP and LVEF over 6 cycles every 2 weeks. And they kind of stratified patients into normal BNP versus persistently elevated BNP. And so what they saw is that patients that had normal BNP, looking at 12 months after their chemo, had a relatively preserved EF, whereas the patients that had persistently elevated BNP had more of a decline. And so they concluded that perhaps it can be a marker. I think it still has some utility as long as we keep in mind that there are other things that can cause stretch of the myocardium and can cause an elevated BNP, and so we just need to keep that in mind. So now, the last little bit, I'm going to talk about management. So unfortunately, there are no great direct treatments for anthracycline cardiotoxicity. The goal from a cardio-oncology perspective is to really allow cancer therapy to be administered with maximal effectiveness with minimal cardiotoxicity so that they can get their cancer treated. And so ways that we look at management is strategies to mitigate damage. We look at evaluation of other causes of heart failure, and then actual management of heart failure. So when we talk about mitigation, we can look at the oncological perspective. So that could be limiting the dose and the schedule, as we saw from the Von Hoff paper. That makes a difference. Looking at more innovative delivery systems. So liposomal anthracycline has less events. Chemical cardioprotection. We're going to talk just a little bit about dexrazoxone in a couple of slides. And then also just stopping the agent. When we look from the cardiac perspective, we look at a lot of risk factor modifications. So patients that have diabetes, hypertension, hyperlipidemia, we want to make sure that all these risk factors are controlled so that the heart doesn't take additional hits. And then obviously, as I mentioned before, we want to look for other causes of heart failure and other things going on so that we can A, treat it, and B, make sure we're not stopping chemo that could be life-saving for their cancer because of other causes and not because of the chemo. Hypertension has a specific important role, mainly because it's very frequently reported as a comorbid condition. So this was looking at comorbidities in a cancer registry. And hypertension is one of the most frequently reported comorbidities. And this is a paper looking at patients that were treated with anthracyclines for various different various different cancers. And when they stratified patients with arterial hypertension versus without, there's a much increased risk of systolic dysfunction with the completion of the therapy in patients that had hypertension as opposed to patients without hypertension. So there unfortunately isn't any specific data looking at a cancer population because a lot of the data and a lot of the trials, cancer patients are excluded. So we generally kind of extrapolate data from the regular guideline management of HFrEF. And so we kind of go to a goal of about 130 over 80. And then when we look specifically at heart failure management, this is, again, a lot of it is extrapolated from guideline-directed medical therapy for HFrEF treatment. So when we're thinking about our stages of heart failure and where we can intervene, I mentioned the risk factor modifications, so making sure the patient's blood pressure, diabetes, et cetera, is controlled. And then once they start developing structural disease, is getting them on good guideline-directed medical therapy. So these are our typical armamentarium, ACE inhibitors, ARBs, beta blockade, aldactone, and then, as we know from the paradigm trial, Entresto. But the key point that I want to make here is that when we're treating things like risk factors like hypertension, we preferentially want to use medications like this rather than, say, a run-of-the-mill hypertension patient using amlodipine. We can get more benefit out of patients using ACE inhibitors, ARBs, things like that as more first line rather than other things that are recommended as per regular JNC criteria. There's again, not a whole lot of data, but I found this one interesting paper that was from the same group that looked at the troponins and looking at modern heart failure treatments for anthracycline cardiomyopathy. So they looked at 201 patients that had a decreased LVEF from anthracyclines, and these patients were started on enalapril, and then if they could tolerate it, carvedilol as well. And what they saw is that there were these three groups of patients. There were some patients that were responders. So these were patients whose EF actually ended up recovering to normal. There was a group of patients that were partial responders where the EF increased, but not to normal. And then there were patients that were non-responders that didn't have any improvement in their EF. And then they looked at kind of different variables that might explain why some patients were responders and some weren't. And interestingly, one of the major factors that they saw was actually time to starting patients on these heart failure medications. So they saw the greatest number of responders in patients that were started on their therapy within 1 to 2 months of their diagnosis. Whereas if you waited till out to 6 months after diagnosis, there was no significant, there wasn't any marginal benefit there. And then when they looked at patients in these groups, they saw that the responders, when they looked at events, had much less event rate than the non-responders or partial responders. So this just kind of goes to show that it's important to get patients on these heart failure medications early on. I'm just going to talk briefly one slide about dexrazoxone, which is an iron chelator. So I had mentioned early on when I talked about the mechanism of action with the doxorubicin and iron, that can cause reactive oxygen species. And so dexrazoxone was studied by Swain's group, and they looked at two different studies, and they looked at patients that had anthracycline exposure that were half of them were, or some were given dexrazoxone and some were given placebo, and then looked at the proportion of event-free rates here. And so they saw in both studies, actually, patients that were treated with dexrazoxone had less events than patients on placebo. The issue, however, that they noticed with that is when they looked at objective response in terms of the cancer treatment, at least in one of the studies, when they looked at complete response and partial response, the group that was treated with dexrazoxone actually had less, a little bit less response to the cancer treatment than the placebo group. That didn't bear out in the other study, but this brought up the idea that perhaps the dexrazoxone could interfere with the chemo. So even though you're kind of trading off the cardiotoxicity for not treating the cancer as effectively. There's more recent data coming out on this, but as of current guidelines, this is not used a whole lot, but there is some potential use for this. So just as per guidelines, when we kind of think about a follow-up algorithm, so when patients are starting on these toxic therapies, the recommendation is to get a baseline LVEF, and preferably with a 3D echo, as we saw with our data, and then getting GLS as well as a troponin, and then monitoring these patients to see if they develop a decrease in EF or GLS or developing troponins. And if they're not, then they should continue their follow-up. And one little kind of tidbit, which is based on some of the Swain data and some of the endomyocardial data, is that if you're starting to get to doses higher than 240, then they recommend kind of more additional and closer follow-up. So the last little bit, I just have a couple slides on some selected chemotherapy, namely the couple agents that our patient was exposed to. So Trastuzumab is antibody against HER2. So HER2 is normally, it's this receptor here that gets dimerized that is involved in different signal transduction pathways. And so Herceptin kind of interferes with this, which can lead to cell lysis and endocytosis of the receptor. There's a large trial called the HERA trial that was mainly looking at the efficaciousness of Trastuzumab, and this was an 11-month follow-up, but they also looked at cardiotoxicity, and they saw that in patients that were exposed to 1 year versus 2 years, there was an increased risk of primary and secondary endpoints. 4% at 1 year and 7% if you continued on for 2 years. And the endpoints that they looked at, primary was patients that had NYHA class 3 and 4 symptoms with a dropped EF, and secondary was class 1 and class 2. Alkylating agents, these are ones that directly affect the DNA and affect DNA replication that leads to cell death. So things like cyclophosphamide, cisplatin, these can have arrhythmogenic effects, heart failure, myocarditis, ischemic cardiomyopathy. So these are all things to look out for the alkylating agents. Taxols, these are things that are microtubule stabilizing agents. And so it actually stabilizes the microtubules, which then interferes with cell replication. So this is like paclitaxel, and you can see effects like bradycardia and heart block. And then lastly, tyrosine kinase inhibitors. So tyrosine kinase is an enzyme that's used to phosphorylate and cause kind of different signal transduction cascades that can result in cell survival, proliferation, etc. And so a lot of cancers can have mutations that kind of enhance this. And so TKIs are a class of medications that block these at various different levels. And you can see patients develop heart failure, conduction abnormalities, QT prolongation, thromboembolism, ACS, and hypertension. Just a couple specific TKIs I wanted to point out. Bevacizumab, which falls under the VEGF category of TKIs, are notorious for causing hypertension. This is just a quick data from a meta-analysis that looked at patients that were treated with bevacizumab versus a control, and there's a significantly increased risk of developing malignant hypertension. So that's something to watch out for. Sunitinib and sorafenib are these multi-targeted TKIs, so they target multiple different areas, and they can cause MI, hypertension. And then dasatinib, I sort of alluded to earlier, can cause pulmonary arterial hypertension, as well as pleural and pericardial effusion. So these are just some selected chemotherapy agents. Future directions for cardio-oncology, there's some work going on in looking at genomic risk assessment. So why do some patients develop cardiotoxicity and congestive heart failure, and some people don't? That's being looked at. We're continuing to review cardioprotection. There's some work going on at looking at strain and CMR for this kind of subclinical detection. And then there's also work looking at patients that have already developed CTRCD. Are there regenerative therapies from stem cells and things like that that can attenuate fibrosis, ventricular remodeling? So just kind of looping back to our case conclusion. So this patient was initiated on beta blockade therapy and an ACE inhibitor therapy. She was cleared for getting her mastectomies. So she actually just underwent her bilateral mastectomy and seems to be doing okay. So now oncology is determining whether she needs any further radiation, maintenance Herceptin, and then we will continue to follow her to see if she has hopefully any kind of recovery of her EF, or at least stabilization of her EF. So in summary, anthracyclines cause cardiotoxic effects in a dose-dependent manner. The recommended max dose now is 450. Diagnosis relies on echo CMR, but there are other potential subclinical markers of dysfunction that we can look at before reduction in EF, and that's where we want to try to catch patients. Management strategies include risk mitigation and just treatment of heart failure with guideline-directed medical therapy. And then just being cognizant that chemotherapy of any kind can have varying effects on the heart, so providers must be vigilant for these side effects. So these are my references, and thank you to Dr. Baldassari and Dr. Hull, who have been my cardio-oncology mentors, and then thank you to the rest of the cardio-oncology team, Jessica, one of our APRNs, Erin and Angela, our advanced fellows, and then my co-fellows as well. So thank you.
Great job, Krishna. That was really, really great. There's been kind of a side conversation in the chat. I can kind of try to quickly summarize it, but there was one quick question from somebody. Did the patient have GLS on their baseline echo, or was that not performed?
I don't believe it's performed, unfortunately.
Okay.
Yeah, that would have been a nice comparison to see from the initial baseline to the follow-up, or if the patient had any follow-up echo in the interim, like that patient case from the meta-analysis at GLS, that would have been kind of a nice case example.
Great. And people can read the chat if you haven't, but there were just a couple of questions about extracellular volume calculation, and how easily is that done? How reproducible is it? You can kind of look at the comments for specifics, but in general, we don't do it routinely on a clinical basis, although we do it routinely. We do it on a clinical basis when asked. It just requires some additional sequencing. As you went through with the T1 mapping, we do pre-contrast, post-contrast T1 mapping, and use the hematocrit to calculate that. It's a little bit labor intensive, but can be done and is becoming more and more automated as they're increasing the software capability a bit better with every version. There's some differences, kind of similar in the in the sense of strain limitations where you have different vendors, different scanners. So you can have some variability in that, and it's recommended that each institution create its own normal values. But in general, there's a standard normal of about 25% similar to the global longitudinal strain data, where there's some variability, but in general, the consensus has landed around the -18 to -20% as a normal reference. Kind of overall seems to be pretty consistent. And then there were a couple questions about treatment of blood pressure and agents, and Dr. Hall gave some responses about our practice and our Cardio-Oncology clinic, which is basically that patients who are otherwise indicated for antihypertensives, we do go ahead and treat them with beta blockers and ACE inhibitors, and if they're already on something else, we usually switch them over. You went through the data. There isn't clear data yet about true prophylaxis in patients that have absolutely no indication at all for antihypertensives. We're not starting patients on that, but we certainly look for reasons. If they're even pre-hypertensive, we usually treat during their therapy at least. And I think I hit on kind of, those were the two kind of major conversations and questions. And there are many, many, many comments about what an excellent talk it was, because it truly was very comprehensive and clear. And I think we had about, at one point, 99 participants, almost 100 participants today. So really great to see everybody virtually at Grand Rounds today amongst the craziness. I think it's nice to see everyone back at Grand Rounds and together as a group. So thank you, Krishna, for an excellent presentation. And I don't know if anyone has a question, they can wave their hand or send another chat, but I think we've reached pretty much everything, and we're 5 minutes over, so probably should end, I think.
Hi, Lauren. Thank you very much, Krishna. And Lauren, thank you so much as well, and to the whole group. Just to thank everyone again for logging in and joining Grand Rounds. We will be here same time every Tuesday at 8 o'clock for virtual Grand Rounds. And next week we have Dr. Herman Taylor and Swati Shah the week after from Duke. So please join us. We'll send out more details about Grand Rounds, and also look on your email for details for CME and how to claim credit for these talks after you've logged in. But thank you again to everyone, and to Liz and the rest of the group for putting this together. We'll see you again next week.
Thank you, everybody.